Good afternoon, everyone. We would like to welcome you to Wayside Recovery's Maternal and Infant Health Series, where today we have Dr. Sharan Rahman, who will be speaking to us today about pregnancy and eating for two. Dr. Rahman and I previously had a really awesome conversation several months ago about the importance of nutrition, and we knew we haven't covered this topic yet in our Maternal Infant Health Series. So I look forward to hearing from her. I want to again thank our sponsorship. Again, this series through Project ECHO is fully funded through the State Opioid Response Grant for the Substance Abuse and Mental Health Services Administration, SAMHSA, and the Minnesota Department of Human Services, Minnesota DHS. Nothing in these materials constitutes a direct or indirect endorsement by SAMHSA or the Minnesota Department DHS of the content, services, or policies. My name is Nicole Fernandez, and I am the project manager at Wayside Recovery Center, serving women for over 60 years. We take pride in trying to provide holistic services and resources, programming, and care for women in our programming. I would like to give a brief introduction to Dr. Rahman. She has an extensive bio, and I will be reading the short version with you, and I'm sure she'll be happy to share during the Q&A session any additional information she may like to share with you as well. And so I'd just like to share, Dr. Rahman has been in clinical practice for over 30 years. She has provided obstetric and gynecological care in multiple clinical settings, including outside of the United States. One of her current clinical interests is working to end healthcare disparities for women in the United States. Without further ado, I would like to welcome Dr. Sharan Rahman and everyone who is joining us from around the Twin Cities and nationally. Thank you so much, Dr. Rahman.
Hello, can everyone hear me?
Yes.
Okay, fantastic. I'd just like to start off by thanking Wayside Recovery Center for this opportunity. I truly appreciate it. And though I can't see anyone at this point, I'm very glad that you're here, and I'm extending greetings to everyone. I am Dr. Rahman, and as stated before, I am a board certified OBGYN. I have a clinical practice in Philadelphia, and I find that I am, although the plan was to focus on midlife female care, I am finding that the whole issue of increasing maternal mortality, disproportionately affecting Black women, is a concern that we can't afford to ignore. I think that we should all share information, put our heads together, and just work towards finding solutions. Next, please. During this very brief encounter, I will just give an overview concerning maternal mortality, discuss CDC recommendations, and then focus on food, EDCs, supersize, ultra-processed. What does that have to do with possible maternal morbidity or maternal mortality? I have a hypothesis. I'd like to share it with you, and also possible suggestions for consideration. I have no financial disclosure. What we're looking at is maternal mortality in the US as reported by the CDC, looking at 2008, 18, 2019, 2020. Just so that we're all on the same page, a maternal death is defined by the World Health Organization as the death of a woman while pregnant or within 42 days of termination of the pregnancy, excluding accidental or incidental causes. The maternal mortality rate is the number of maternal deaths per 100,000 live births. And just as a visual, you can see that in the US, from year to year, from 2018 to 2020, the number of maternal deaths has increased. The maternal mortality has increased each year. Now, just the information about the collection of this information. The CDC collects this information, but the initial information is generated by a death certificate, which is completed by a physician. After the physician completes the death certificate, it's reported to the state, and then the state sends their information to the CDC. For the longest, the question of was this a maternal death, or had this death occurred within 42 days of a delivery, was not included in the birth certificate. And in 2003, the CDC asked the states to start including information about possible maternal deaths. Each state was allowed to do it at their own pace, and the last state to include a box on their death certificate regarding maternal mortality was in 2017. So I say all that to say we have not done a good job in just collecting the statistics. But since 2017, 2018, all 50 states now include a box for maternal morbidity. Now, looking at the information, you can see that non-Hispanic Blacks are the maroon box. And you can see that from year to year, non-Hispanic Blacks have a higher rate of maternal mortality. If you look at non-Hispanic Blacks, their box, you'll see that in 2018, the maternal mortality was 37.7. In 2019, it increased to 44, and then there was a fairly dramatic increase from 2019 to 2020. There are no clear explanations for that. Question, could it have been COVID related? Maybe too soon, but that is a consideration. But irrespective, we see that non-Hispanic Blacks have a much higher incidence of maternal mortality. Next, please. Dr. Susan Bailey, who is the president of the American Medical Association, had several statements to make about this. And she said that when we compare our country's maternal mortality to other developed countries, we have the highest rate of maternal mortality. And that it is almost twice as high as other nations of comparable wealth. That's a damning statement. And when we look at the reports from the CDC is of the opinion that 60% of these deaths are preventable. And for me, that's the real clincher here. If they are preventable, why is it so high? And that's the question. And that's where we have lots of work to do and lots of research. We need to figure out what is the issue. Next slide, please. So going to the CDC site, when you ask the question, what can women do to prevent a pregnancy-related death? What you're seeing are the options that are given. Maintain a healthy diet, maintain a healthy weight, be physically active, quit all substance abuse, prevent injuries, address any health problem before getting pregnant. And while that all sounds good and reasonable, it doesn't seem to explain the disparity or why we would have an increasing rate in our maternal mortality. But there is one particular issue that stands out to me among these 6 possibilities, and that's the whole idea of having a healthy diet. And that's what I'd like to focus on a little closely. Next slide, please. Again, this is taken from the American College of OBGYN. It's the recommended weight gain for a woman who's carrying a single pregnancy. And we use the determination as to what is her body mass index, meaning the more she weighs or the higher her BMI, the less weight we would want her to gain during the pregnancy. But if you look at the other chart on this slide, the percentage of women below, within, or above the pregnancy weight gain recommendations, you'll see that only about 32% of the pregnant women actually gain weight within the recommendations that you see just to the left of this diagram. Almost 50%, 48% gain more than the recommendation, and about 21% gain less. And so this is interesting because we seem to be missing the point. Next slide, please. The question is there miscommunication? Is it because we're talking about BMI and women don't understand what BMI is? Is it because there's not enough dialogue about weight gain and a proper nutrition? Is it because OBGYNs don't feel that this is in their purview, that this is not something that they're knowledgeable about, or something they feel comfortable discussing? Is it because they feel that it's a futile issue and that most women expect to gain weight? Most women do not necessarily count calories or try to maintain a certain weight gain during their pregnancy. And so there are a lot of questions about what's being said and what do we think is important in terms of weight gain during the pregnancy. The whole idea of eating for 2, what does that mean exactly? Next slide, please. And so I'm going to make a huge jump to talk about something called EDCs, or endocrine disruptive chemicals. And the question might be, what does this have to do with food? And the answer is that one of the main sources of our exposure to EDCs is through our diet, through the food that we eat. And EDCs are chemicals, and these chemicals have an effect on our reproductive system. And not only are these chemicals in our food, they are in our hair care products, they're in our cosmetics, they are ubiquitous. And what we know about them is that they can have a negative effect on the reproductive system. And if this sounds a little unbelievable, all we need to do is take a moment and remember the history related to DES, diethylstilbestrol, DES, which was a synthetic estrogen that was given to pregnant women to reduce the risk of pregnancy loss. This synthetic hormone was given to women in the 1940s and the 1950s, up until 1970s, when it was realized that it was causing reproductive abnormalities in the children of the women who were given the DES. The children of the women who were given the DES were having reproductive abnormalities. The females' daughters were having an increased risk for clear cell adenocarcinoma of the vagina and the cervix. And now they are still collecting information about the grandchildren of the women who were given EDCs, specifically DES, during their pregnancy. And I mention that to say that the effect of endocrine disruptive chemicals can be pervasive. It can affect multi-generations. And so we need to consider this. And if the food we're eating is a source, we have to consider the role that it may play. Next slide, please. This is just a visual to show you all the various sources of EDCs. We can get it from food preservatives, personal care products, from plastics, from food packaging, clothing. It's ubiquitous, and that is part of the problem. The problem is that we are being exposed to these chemicals, and the question is, are Black women being exposed to these chemicals at a disproportionate rate, a disproportional amount? And could this be contributing to the problems that we're experiencing? Next slide, please. Oh. One of the EDCs, a group of EDCs have been associated with increasing weight. There's evidence that when women are exposed to the EDCs, these EDCs are called Obesogens. And as Obesogens, it makes it easier for women to gain weight. And these Obesogens have been detected in packaging from fast foods and also personal hair care products. Next slide, please. So the question is, how can you avoid the EDCs? And one of the recommendations is to avoid plastics, canned foods, and also to put your packaging either in glass or stainless steel containers. Next slide, please. The other recommendation is to consume more organic food than conventional, and that's because with conventional foods, there are more chemicals used in the pesticides, which are being used to kill insects and to facilitate the growth of the plants. So these are, and then the next slide, please. Healthcare providers need to be aware of the effect of endocrine disruptors and how they can affect women during pregnancy and preconception. The American College of OBGYN and the Federal International Association of Gynecologists and Obstetricians have both issued statements. In fact, the American College of OBGYN has recently updated their statement to say that it's prevalent that obstetricians need to discuss this with their patients, and they realize that women of color and women who live in economically deprived areas tend to be at an increased risk for exposure to EDCs. And then that raises the question, is this why we see a disproportionate effect with Black women in terms of maternal morbidity, and maternal mortality. Next slide, please. The other thing that we need to consider is not only what we're being exposed to, but how much are we being exposed. This is a representation of what's called a boiler chicken taken at 3 different points in time. This is at a point where the chicken would be slaughtered, and boiler chickens are raised for the meat. These are not the egg raising birds. So you can see when you're comparing 2005, the size of the chicken in 2005, to the size of the chicken in 1957, you can see that the chicken, today's chicken, is significantly larger than the chickens of the past. And how was that done? That was done because A&P Pharmacy invited poultry farmers to send their fastest growing chickens to the agricultural department. And then with selective breeding, they were able to create a fast growing chicken where it had significant breasts, plumper thighs, that would grow at a faster rate and need less feed. As a result of that, the price of chicken went down while the consumption of chicken went up. It's estimated that Americans ate 8 million chickens last year. I'm sorry, 8 billion chickens last year. Excuse me, I just lost my place. Next slide, please. But there's a problem. This is a chicken that's about 42 days or 7 weeks. And because it's one of these supersized chickens, it has a stressed heart, has a hard time moving because the legs are weak and unable to support the big body. It said that if this chicken is not slaughtered within the next week, it will die just from an overworked heart. Next slide, please. But it's not just the oversized chicken. If you look at the size of our drinks, you'll see that in 1955, an average size drink from a fast food type place would have been 7 ounces. Compare that to in 2006 with the gulp, significantly larger. When you look at a 20-ounce bottle of soda, a 20-ounce bottle of soda will contain approximately 16 teaspoons of added sugar. And that's more than an adult should consume in an entire day. And it's probably, people are probably drinking more than that in a given day. There was an evaluation of how much added sugar was consumed by race and ethnicity. African Americans assumed 19 teaspoons in a given day of added sugar, non-Hispanic whites 17, Hispanic 16 teaspoons of sugar, and Asian 10 teaspoons of sugar. And so again, we have to wonder, is it the EDCs? Is it the amount of sugar? Is it what we're eating that's contributing to the disparities that we are seeing and that we're having a difficult time explaining? Next slide, please. And then we have what's called the ultra-processed foods. You know, those are the ones that you say, I bet you can't eat just one, okay? Ultra-processed foods are pretty much manufactured for taste and not nutrition. In the diagram, in the picture that you're looking at, some of these foods are considered ultra-processed and some aren't. I'm wondering if you can decide which is which. Ultra-processed foods is part of the definition classification of foods called NOVA. There are four groups. The first group is considered raw or minimally processed. The second group, the second group is considered food that's been extracted from natural or minimally processed foods that are used as seasoning and savoring for food. Processed foods or minimally processed foods are when you extract oils such as olive oils and you add it to minimally processed foods. So I'll try to explain that a little bit more. An example of a group one food, raw or minimally processed food would be a potato. Even if I bake that potato, that would still be considered a raw or minimally processed food. Now, if I brought the raw potato home, and I used oil, which had been extracted from an olive, and I used that to fry the potato, and I now had French fries, that would be a processed food. All right. But if I go to the store and I buy a Ruffles onion flavored and sour cream potato chip, that's an ultra processed food. Some people define an ultra processed food as something that you can't cook at home. I mean, you can't make a Dorito in your kitchen. The other thing about ultra processed foods is that it's about the taste. They are created by food industry who have studied and developed artificial taste and then package it into foods. And they take food extracts and they combine it and they give us these products. There's little or no fiber in ultra processed foods. And fiber is that ingredient in raw and minimally processed foods that gives us a feeling of fullness, satiety, which means that if we don't have that, we don't know when to stop eating. And we eat, and as a result, we consume a lot more than we might normally do. There are very few or no nutrients in ultra-processed foods. And part of the reason for eating, in addition to enjoying it, is to be able to get nutrition. The other factors associated with ultra-processed foods is that there is increased salt and increased sugar in the ultra-processed foods, along with many empty calories. And so there is an increased association of weight gain with ultra-processed foods. Now, the caveat is that ultra-processed foods are usually very convenient. They're easy to access. They have a long shelf life. You really don't even have to cook them that much. They're almost ready to eat. And so that makes them seem at times more desirable or easier. Next slide, please. So when we are faced with these choices, what do we do? What do we do? We know that ultra-processed foods are associated with obesity. We know that ultra-processed foods are associated with hypertension. And so we wonder, could this be part of the reason that we see Black women are disproportionately affected with adverse pregnancy outcomes, because the statistics have shown that cardiovascular disease is one of the leading causes for maternal mortality. And one of the reasons for maternal mortality has to do with hypertension and obesity. And we know that Black women have a higher incidence of obesity, and we know that Black women have a higher incidence of hypertension. And could it be the food? Next slide, please. So here's the alternative: the raw or minimally processed foods. These are the natural foods. These are the foods that have fiber. These are the foods that have the maximum nutrients and vitamins, little or limited, no or limited sugar or salt, fewer calories. The downside is that they have to usually be prepared. There's always the question of cost, particularly in a time like we're living, when we're seeing cost for food when we go to the supermarket increasing almost on a weekly basis. The question is, can you afford it, or can you afford not to? Next slide, please. So to do kind of side-by-side comparison, I would say that ultra-processed, think artificial, but think they will appeal to your taste. Fiber in minimally processed foods, little or no fiber in ultra-processed foods. Maximum nutrients and vitamins in raw or minimally processed, not so much with ultra-processed foods. Lots of salt and sugar in ultra-processed foods, lots of empty calories in ultra-processed foods, but they are quick and easy to fix. The healthier choice is a minimally processed food. Next slide, please. So we're looking at this, but why is it so hard? I mean, if you found the pictures with the cookies and the potato chips and the sodas more appealing than this, then the question is there an addictive quality to ultra-processed foods due to the amount of sugar and the salt in the food? Next slide, please. And then the other question that begs to be asked is it a matter of convenience, or is it because we don't know how to cook anymore? Is it easier to buy something that's ultra processed and give to our families and eat for ourselves? Or is it better to learn how to budget, how to meal prep, how to cook, how to use seasonings? And if that's a better choice, then what are we doing to make that an option for women? How do we get that information to women that they can use, that they can figure out a way to prepare meals for their families in a way that maximize nutrition at the same time as saving money? Next slide, please. So this is my hypothesis. It kind of goes back to the chicken. Through breeding and diet, they were able to create the super chicken. And now we are exposed to EDCs, which have obesogens, which can increase fat. We're also exposed to ultra-processed foods, increased sugar, all of this leading to increased obesity, which could possibly lead to increased cardiovascular disease, which could possibly lead to increased Black maternal mortality. And if this is true, if this is possible, then we have a reason to be somewhat optimistic in that there's something that we can do. We know that racism is real. We know that there are a lot of things that are hard to fight against, but if changing how we eat, if changing the way we cook can affect maternal mortality, then it's worth a consideration. Next slide, please. And so the question is, was it in front of our eyes all the time? And that what we need to do is avoid the chemicals as much as possible, eat the nutritious foods, and learn to cook. I'm not suggesting that that's the only thing that we need to do, but I believe that it will go a long way in helping us to have healthier lives and also healthier lives for our children, our progeny. Thank you.
Thank you so much, Dr. Rahman. Oh my goodness. I am sitting over here, I think very, my mind is thinking about so many things that I know, that maybe we know or have known or wondered and questioned. And I just think you've put such deliberate, intentional, and valuable information before us this afternoon, and I am grateful. We know that this is a time where we'd like to open it up for questions. Because we are in the webinar format, I apologize, I didn't share this in the beginning, that you do not get to see the audience. However, they are present and they are on mute. But anyone who has questions for Dr. Rahman, please put your questions in the chat. I will help to moderate this portion. We would love to hear from you, what you are thinking and how you may apply some of this information in community with your clients, family, and or those that you provide services to. So please place your questions in the chat. While we're waiting, I guess one of the questions that one of my wonderings is, what do you really think the problem is? I'm sure other providers such as yourself and even in your practice, when you're sharing these recommendations to moms or young women, what do you think is the barrier for us making better choices around food? Or what are you hearing the number one barrier might be to our communities of color or otherwise?
I think it's multifactorial. I think we don't think of it as being a bad thing. I mean, we think that there's nothing wrong with consuming ultra-processed foods. We think there's nothing wrong with gaining 50, 60, 80 pounds during a pregnancy. We're eating for two. We think there's nothing. And on the practitioner side, we may not stress it enough. I mean, we're measuring the fundus and we're listening to the heartbeat, but we're really not trying to get to the root, which might be your eating should be better. When you're eating for two, you should be eating well. And eating well doesn't necessarily mean eating more, you know. And so we need to kind of shift the thinking about what we need to do and how we need to get the message through. And as an OB, we might say that's not in our purview. Send her to a nutritionist. Have her go to the WIC office. And so we're passing the baton and we're saying, no, that's not what I do. You know, that's not my job. But I think it's important, especially if we think that it's contributing. The food is contributing to the obesity, which is contributing to the cardiovascular disease, which is contributing to the mortality. Now, if we believe that there is a direct connection between food and maternal mortality, then we need to focus on the food. We need to help women figure out how to, meal prep, how to budget, how to do those things so you're not running to the corner store and buying some fast food to feed your family. If you know how to meal prep, if you know how to budget, if you know how to cook, you could actually save money. But do we do that when the option is right there? We can just pull it from the shelf, open it up, zap it in the microwave, and it's done. And we think that's okay. And the message might be that's not the optimal way to go.
Thank you. I have a follow-up question, and we do have about 3 questions, and this is more personal. So when I was a young mom, I gained 60 pounds. I gained 60 pounds with all 3 children throughout, and which is a different in 10-year span. But I also lost that 60 pounds and went back down to a size 8 after delivery. I didn't know why I gained so much. And I was told, well, maybe it's fluid. But I'm wondering if, and this was in Massachusetts and Minnesota, I remember going to prenatal classes, right, as a new mom. But I wonder if it would be helpful, and are there any suggestions that you also go to a nutrition class early? Is that a recommendation that would maybe help women? Okay, yes, learn about delivery and some of those things and preparing for baby, but maybe should we be prescribed a nutrition class early on? In terms of like what you just gave us would have really made me more aware of not just giving in to cravings, but making better choices. Like you're saying, I'm eating for 2 to be well, to have a good pregnancy.
And I think that's the word you said, cravings. I think ultra-processed foods create cravings. And that's in the background of people telling you, go ahead and eat.
Yes.
You're pregnant. You're pregnant. It's okay. And we do. And you're one of the lucky ones that you were able to lose your weight, but sometimes you don't, and you just keep adding on. And then we have issues. And on a personal side, I have to say that if I have to do surgery on a woman that weighs 120 pounds compared to a woman, all other things being equal, to a woman that weighs 240 pounds, it's going to be an easier surgery with the woman that weighs less. And so those are some of the realities of care. And I think we just need to be very real with people, meaning ultimately it's your body, your choice, your life. All right. But you need to have the facts. You need to understand as best that we understand, even if the understanding is we're not sure. But clearly we can see that there's something strange here, and we need to explain it somehow.
Thank you. So the question that we have in the chat, one of the questions says, do you think food deserts impact Black women's health outcomes?
Absolutely. If all you have is a corner store with potato chips and soda, and there is a scarcity of fruits and vegetables, or even a lack of, in the picture that I showed of fruits and vegetables, it looked like a rainbow, all different colors and types and shapes and sizes. But if you go to a corner store and all you see is an apple, it's going to be a disincentive. There are lots of different fruits and vegetables. There's lots of different seasonings that you can make your food taste different ways. But if you don't know how, or if you don't even have the opportunity, meaning that you're in a food desert, then it just is harder to do.
Thank you. And then a follow-up question to that is, how can communities use the information you provided, this information, for better reproductive care? How can communities of color become empowered with this information?
Well, there are a lot of those, they're called community gardens, where they grow fruits and vegetables. Now, if you're growing your own fruits and vegetables, they're organic, okay? Meaning that not as much pesticides. So if you can come together in a coalition and grow your own food, that's huge. I think that we need exposure to being able to cook and being able to cook well. I always say, there's the, I think it was Sonia Sanchez that talked about our creativity and our ingenuity, and we were able to take guts and make chitlins and blues and make jazz. I mean, we have that creativity. And so if we can use it in a way that promotes our health, then that's huge. I mean, but we have to see that there's a need for it, and we have to get creative about our cooking and creative about how we do things. Yeah.
Wonderful. That intergenerational knowledge and wisdom, that food was healing for the communities of color, our communities of color. Food has always been a source of health and wealth in many ways. The final question, as I'm looking at time, is what should providers be doing to change Black maternal health outcomes? Based on the information you share with us today, what should other providers be doing from the wisdom that you've provided today?
Yeah, that's a hard one, because there's the ideal and there's the reality. I mean, meaning that a lot of times there's not a lot of time to engage in a conversation with your patient. I mean, you have to get them in and get them out, okay? And I think what we can do on a personal note is educate ourselves about EDCs, okay? We need to be able to not make someone feel bad about themselves, but have them know that, if you cooked, or if you were able to make your own food, you could stretch your meals, you can enjoy different meals. So there are opportunities. So we have to encourage women, when they're eating for two, to eat well, not more, but to eat well.
Wonderful, wonderful. Thank you so much. I am just thinking about a lot of the great work that's happening in Minneapolis and St. Paul area. And I'll just share this because I don't know the constituency that is on, but there's been many organizations who provided food for family, through food boxes that was organic, that was natural foods for families in need. I know we have different organizations and institutions that were providing cooking classes, right? Not just for youth in schools, but they were doing in community. Then I also know many of the local clinics in the summer months have farmers markets where they're giving away fresh food and produce. So just to share with our constituency and thinking about who can we partner with and just say, hey, we provide care to women, right, and recovery, or we're providing care for women in maternal infant health or women's health. How can we get good foods to these families and remove the barrier of cost, et cetera? And one of them, I do know, they delivered the food to your home. So just hearing this amazing information from you, I knew I was excited about your talk and just so grateful. But I just want to say for the audience and for Wayside, we so appreciate you, Dr. Rahman, and we want to stay in connection with you and your great work.
Thank you. I really enjoyed this.
Thank you. Thank you all for attending. Please look for your survey that will be coming out in the next 24 to 48 hours. Dr. Rahman, are you okay with us sending a PDF or sharing it, your presentation, with anyone who has attended and might be interested?
Sure, that's fine.
Wonderful. Thank you so much. So please stay in contact, and we hope that you will continue to follow our series. Have a great afternoon, everyone.